So let's hit on DKA today and what the CCRN exam likes to test on. So we know that insulin is non-existent, right, or very low in DKA patients. What this leads to is fat breakdown, and that literally is lipolysis. So when fat's broken down, it forms free fatty acids. These get taken to our liver and essentially make ketone bodies. This is what our body starts to use as a fuel source. But ketones are big acids. So essentially, what happens is we go into metabolic acidosis. The other thing that people miss a lot is that these patients are massively dehydrated, and they're actually in hypovolemic shock from this severe dehydration. And this actually occurs from osmotic diuresis. Basically, all that means is once our sugar gets so high, we start spilling it out into our urine. This is why we see that in these patients. But water is also attracted to glucose. So we start peeing out glucose, we start peeing out water, and we become extremely dehydrated. This is what leads to the common signs and symptoms that we see with DKA patients. One of those being Kussmaul's respirations. And these are deep, rapid respirations that our patients are trying to blow off CO2. This is why we do that, to try to compensate, because our blood is so acidic that any added extra acid really can throw these patients off. And if you remember, CO2 technically is an acid. So we want to blow this off, and that's why we see this in patients. We also talked about how dehydrated these patients are, right? And it's from the osmotic diuresis. So these patients are peeing a lot and they're very dehydrated. So you'll have dry mucous membranes. You might even have skin tenting. These patients can be tachycardic and hypotensive. Finally, one of the most tested things we see on the CCRN exam is how they actually diagnose a patient with DKA. Obviously, a high sugar is one of them. So it's greater than 250. But the other thing that's really important is these ketones that are found in both our blood and in our urine, because this is proving that we are breaking down fat and forming these ketones, which is leading to the metabolic acidosis seen in these patients. The other thing that we see as well is a low bicarb. So anything less than 18 is considered a low bicarb. And we see this because, if you remember, bicarb is a buffer. So our patients are massively in metabolic acidosis, and our body is trying to buffer that with bicarb. So essentially, it gets eaten up, and that's why it's low. The last thing that we see is this large anion gap. What's important to note about this is that a high anion gap literally is telling you that there is acid that's unaccounted for. So something out of the ordinary. We don't know which type of acid. So it could be someone has a high lactate. It could be that these patients have ketone bodies like in DKA. But this is extremely important to note because we know that when we have a high anion gap, there are lots of acids that are present. We know this is occurring in DKA because we've switched our fuel source from glucose to fat. And when we break down fat, we make ketone bodies, which are acids. So you're going to see this high anion gap acidosis in these patients. Tomorrow, we're going to hit on some important electrolytes that we need to monitor and the actual treatment for DKA and why we do what we do. So check it out.